We will now discuss compartment syndrome, which can be defined as acute ischemia in an osteofascial compartment. It is also known as acute compartment syndrome, or ACS. The mechanism underlying compartment syndrome is due to the competing pressures present. There is perfusion pressure provided by the arterial and venous supply, as well as physical compartment pressure. The perfusion pressure must remain higher than the compartment pressure, otherwise there will be a decrease in perfusion and resultant ischemia. The increased compartment pressure can originate from increased compartment contents, such as edema, hematoma, or a fracture, and it can also originate from an increased extrinsic pressure, for example, from tight dressings or POPs. Compartment syndrome can present either with early warning signs or late signs. The early warning signs include a pain that is out of proportion to the apparent injury, as well as a persistent deep ache and or burning pain even after immobilization. There can also be paresthesias present with an onset time of approximately 30 minutes to 2 hours within the onset of ACS, as well as pain on passive stretching of the muscles within the affected compartment. The late signs include paralysis and absent pulses. Additionally, examination findings suggestive of acute compartment syndrome include a tense compartment with a hard or woody feel, pallor of the affected area, and diminished sensation. For the management of acute compartment syndrome, ideally, if it is suspected, immediate surgical consultation should be obtained. But if the patient is in a remote area without adequate surgical access, the patient should be transferred immediately to a hospital where adequate care can be provided. If an impending compartment syndrome is suspected, the management would include the immediate relief of all external pressures, for example by loosening the cast. You should then place the limb level with the heart to optimize arterial inflow and venous outflow. You should also provide supplementary oxygen and analgesics if required. If there is hypotension present, treat the patient with boluses of IV isotonic saline, as hypertension reduces perfusion, which can worsen the tissue injury. If there is established compartment syndrome, the definitive treatment involves a fasciotomy across the joint to release the pressure. This incision should then be covered with a suction